The AANA Research and Quality Division has prepared this short video to introduce CRNAs to the new Quality Payment Program that will begin in 2017. The Quality Payment Program, or QPP, was established by the Centers for Medicare and Medicaid Services as part of the Medicare Access and CHIP Reauthorization Act of 2015, also known as MACRA, and applies to clinicians participating in Medicare Part B, including CRNAs. 2017 will be the first reporting year for the QPP, which consolidates and replaces the following quality programs: the Physician Quality Reporting System, PQRS, the Medicare EHR Incentive Meaningful Use Program, and the Value-Based Modifier. The new QPP allows eligible clinicians such as CRNAs to participate through one of two tracks. The first method is through an Alternative Payment Model, or APM. CRNAs who belong to certain APMs can earn a QPP incentive payment. The other method consists of the Merit-Based Incentive Payment System, or MIPS, which allows eligible clinicians to earn a performance-based payment adjustment. The majority of eligible CRNAs will participate in the QPP via MIPS for 2017. Although participation in the QPP is not required, CRNAs are defined as eligible clinicians and will automatically receive a 4% penalty in 2019 if they choose not to participate in the QPP for the 2017 program year. However, there are some CRNAs who will not be able to participate and are considered exempt from MIPS for 2017. These consist of CRNAs newly enrolled in Medicare, such as first-year practitioners, CRNAs with less than $30,000 in Medicare revenue or 100 or fewer Medicare Part B patients per year, and CRNAs significantly participating in advanced APMs. As 2017 will be a transition year for the MIPS program, CMS is allowing participants to pick their own pace. Eligible CRNAs will have 4 options to choose from. If you don't participate, you will automatically receive a negative 4% payment adjustment on your 2019 Medicare reimbursement. If you are only interested in testing the program, all you have to do to avoid the negative 4% payment adjustment is to report on one quality measure for one patient or complete and attest to completing one improvement activity. If you decide to participate, you can submit partial data to earn a neutral or small positive payment adjustment. This requires submitting quality data for any 90-day period between January 1st and October 2nd of 2017. Finally, to fully participate and earn a positive adjustment of up to 4%, you will need to submit data for the entire 2017 year, from January 1st to December 31st. Positive payment adjustments will be based on your performance. It's important to note that beginning with the 2018 reporting year, full participation will be needed to avoid subsequent penalties. The MIPS program consists of 4 performance categories, each carrying its own weight, which will be used to calculate a MIPS composite performance score. The first performance category is quality and replaces the current Physician Quality Reporting System, PQRS. For 2017, the quality category will be worth 60% of the MIPS composite performance score. The second category is new and comprises participation in clinical practice improvement activities, which will be worth 15% of the composite performance score. The third performance category is Advancing Care Information, or ACI, which replaces the current Medicare EHR Incentive Meaningful Use Program. This category will be optional for CRNAs in 2017. It also does not apply to clinicians who are hospital-based or who qualify for a hardship exemption. The last category is cost, also known as resource use, and replaces the current value-based modifier. This category will be weighted as 0% for 2017, but will be re-weighted in 2018. Together, all of the MIPS performance categories are calculated to obtain a MIPS composite performance score, which will be used to determine your performance and resulting payment adjustments. Now let's go through what the full participation requirements are for CRNAs participating in MIPS in 2017. For the quality performance category, all participating CRNAs must attempt to report on a minimum of 6 applicable measures, including 1 outcome or high priority measure for at least 50% of all your patients. That's Medicare and non-Medicare patients. For CRNAs that are reporting on the Advancing Care Information ACI category, the quality performance category will be weighted as 60% of their MIPS composite performance score. However, CRNAs that are not reporting on ACI will have their quality category re-weighted to 85% of their MIPS composite performance score. The next performance category is the new improvement activities. To fully participate in 2017, patient-facing CRNAs must try to complete and report on 2 to 4 activities for a total of 40 points. Improvement activities that are weighted as high are worth 20 points, and activities weighted as medium are worth 10 points. Partial credit is awarded if full participation is not met. The requirements are slightly different for CRNAs who are non-patient facing in groups with fewer than 15 participants or in a rural or health professional shortage area. These providers only need to try and complete 1 to 2 activities for a total of 40 points. For this group, the activities weighted as high are worth 40 points and activities weighted as medium are worth 20 points. Again, the improvement activity performance category is worth 15% of the MIPS composite performance score. Let's go through some important definitions before we move on to the next performance category. Most CRNAs are considered non-patient facing clinicians under MIPS. Patient-facing encounters are defined as instances in which the MIPS eligible clinician or group bills for general office visits, outpatient visits, and procedure codes. The definition does not include any specific type of clinician specialty. A non-patient-facing individual clinician is defined as one that bills for 100 or fewer patient-facing encounters during the performance period, while a non-patient-facing group must have more than 75% of its NPIs billing under the group's TIN meet the definition of a non-patient-facing individual. Most traditional anesthesia services are designated as non-patient-facing. CMS plans to identify and notify CRNAs of their non-patient-facing or patient-facing status based on prior data. Now back to the MIPS performance categories. Similar to the Medicare EHR Incentive Meaningful Use Program, the Advancing Care Information or ACI category will not be applicable to most CRNAs. Therefore, participation in this performance category will be optional for CRNAs in 2017. However, this will likely change in subsequent years. The ACI category will be reweighted to 0% for CRNAs who choose not to participate because they do not have certified electronic health record EHR systems or applicable electronic measures. On the other hand, the ACI category will carry a weight of 25% for CRNAs who choose to participate and have access to certified EHRs that are able to report on the required electronic measures. Again, CRNAs who choose not to report on the ACI performance category for MIPS 2017 will have the category reweighted to 0% for their MIPS composite performance score. Eligible clinicians who are hospital-based or who qualify for a hardship exemption will also have the ACI category reweighted to 0%. Hospital-based clinicians are those who furnish 75% or more of their professional services in sites identified by the specific place of service codes. These consist of inpatient hospital, outpatient hospital, and emergency room. Clinicians who qualify for a hardship exemption must demonstrate that they have insufficient internet connectivity, an extreme and uncontrollable circumstance, lack of control over certified EHR technology, or lack of face-to-face patient encounters. The last MIPS performance category is costs. Data for this category will be collected through administrative claims, but will not be counted toward 2019 payment adjustments. Therefore, the final category weight for cost will be 0% for the 2017 reporting year. The cost category will be reweighted beginning in 2018. So let's review how the MIPS composite performance scores will be calculated for MIPS 2017. CRNAs who participate in Advancing Care Information, ACI, will have 25% of their score allocated to that category. The quality category will be worth 60%. The improvement activities will be worth 15%, and the cost category will be worth 0% for 2017. CRNAs who do not participate in ACI will have the category reweighted from 25% to 0%, and the 25% will be added to the quality performance category, which will now be worth 85% of the MIPS composite performance score. The weights of the improvement activities and cost categories will remain the same at 15% and 0% respectively. In terms of reporting mechanisms for MIPS, a CMS qualified registry allows participating CRNAs to fulfill the quality requirements similar to PQRS. An anesthesia measure set has been finalized for MIPS 2017, which includes 9 measures. Again, CRNAs must try to report on at least 6 of these measures. However, exceptions will be made for clinicians who do not have enough applicable measures. It is important to note that 2 measures were added to the anesthesia measure set that was used for PQRS reporting in 2016. These are number 130, documentation of current medications in the medical record, and number 317, screening for high blood pressure and follow-up documented. All of the MIPS specialty measure sets now include these measures. For MIPS 2017, an added benefit of reporting through a qualified clinical data registry, or QCDR, will be that CRNAs will be able to meet improvement activity requirements in addition to quality requirements, thereby addressing not 1, but 2 performance categories. QCDRs not only allow CRNAs to fulfill the quality category requirements with abundant applicable measures, but also provide ample opportunities for completing and attesting to improvement activities. Participation in other types of reporting mechanisms such as claims, EHR, or traditional registries can be used to meet quality performance category requirements, but are limited to MIPS measures, some of which may not be applicable to your practice or setting. Furthermore, CRNAs who utilize these mechanisms will have to independently find and select appropriate activities that meet the criteria for the Improvement Activities Performance category. The ANA Research and Quality Division is preparing a list of additional improvement activities that CRNAs can complete for the 2017 MIPS. As previously mentioned, 2017 will be a transition year for MIPS. CRNAs can avoid the 2019 penalty simply by reporting a single quality measure on 1 patient or by reporting 1 improvement activity. However, this approach does not help your patients, your practice, or your future. Thus, CRNAs are encouraged to submit data for a 90-day period to earn a neutral or small positive payment adjustment. CMS will continue to finalize program requirements for 2018 reporting and beyond. Therefore, it's important to start preparing now by at least partially participating in 2017. Keep in mind that MIPS penalty and bonus payments will increase over the next 5 years, starting with a plus or minus 4% adjustment in 2019 and increasing to a plus or minus 9% adjustment in 2022. Thus, CRNAs who fully participate in MIPS will be able to benefit the most from the program as it evolves. So how should CRNAs prepare for MIPS? Here are some steps that you may want to follow. First, consider using a qualified clinical data registry, or QCDR, to meet MIPS requirements for both the quality and improvement activities performance categories. Second, decide if you will participate as an individual or as a group. You must register for a group practice reporting option, or GPRO, with CMS by June 30th, 2017. Third, check the CMS and ANA quality reimbursement websites to see which measures and activities best fit your practice. Finally, if you choose to report data for the MIPS Advancing Care Information Performance category, make sure your EHR system is certified by the Office of the National Coordinator for Health Information Technology. CMS has made some QPP resources available through their Quality Payment Program website at www.qpp.cms.gov, including support for solo practitioners and small group practices. The website also provides educational materials and webinars on MIPS and APMs. The ANA Research and Quality Division plans to update our quality reimbursement website with additional resources and tools such as fact sheets, downloadable tables, infographics, and webinars. Thank you for listening.